Thank you for inviting me to participate in this. And my job is to take the elegant science that Claire's been talking about and now think about it from a government regulatory perspective. And certainly part of my perspective in presenting that comes from the 8.5 years I spent at the Food and Drug Administration. So that's sort of the context for my comments. So in thinking about that task, I felt the main question for me to address really is, what are the regulatory approaches for the term healthy and related terms? And I felt that there were two dimensions from that with regulatory implications. One is maintaining the health of the GI tract, and the other is producing a health benefit that may be associated with reducing risk of disease. So I decided to tackle the question by looking at regulatory frameworks that were structured around those two dimensions. And to do that, for the first one, I thought that the framework for nutrition-related claims would be a good way to look at that first dimension. And for the second one, I thought that the recent work from FDA on the framework for isolated and synthetic carbohydrate polymers to be considered as a part of dietary fiber would be a good approach to look at how FDA made a decision for those carbohydrate polymers, and also then the guidance on the review of scientific evidence for claims that are used in food. And I should point out that my focus is really from a food perspective. I'm not going to try and deal with the drug medical device aspect of FDA's work, but really just the food-related aspect. So if we start on that first task then of nutrition-related claims, generally the nature of nutrition-related claims that are made in food labeling, which can be either on the label or in the kind of marketing-related material, can be dietary guidance statements that refer to the presence of certain food groups, such as whole grains, fruits, or vegetables, and how they're part of a healthful full diet. They can be nutrient content claims that explicitly or implicitly characterize the nutrient profile of a food, structure function claims, which are about maintaining health, or health claims, which are disease risk reduction claims, including the qualified health claims that FDA reviews. And these are claims that are based on significant scientific agreement. So for this first one, I really want to focus on the framework around nutrient content claims and structure function claims. So a nutrient content claim, as indicated, they can express the express claims describe the levels. So they're the type of claims that are typically used in conjunction with a daily value, which is a reference value. And so they characterize the nutrient profile of a food by saying it's high in the nutrient, low in the nutrient, excellent source, a good source, that they characterize that level. There are also implicit claims that suggest that a food may be useful in maintaining healthful dietary practices. And the word health and all its related variations, health, healthy, healthfulness, however you choose to reframe the word healthy, healthy itself is regarded as an implicit nutrient content claim. You're using the word to signal that the food has a nutrient profile that's useful in maintaining healthful dietary practices. And so the regulatory approaches for nutrient content claims, first of all, that specific criteria have been established. So you use the percent daily value, or this reference value, to indicate whether something is a good or excellent source or is low in a particular nutrient or nutrient-related compound. And levels such as total fat, saturated fat, sodium, cholesterol, and beneficial nutrients have been defined for healthy. So I'm not going to give you all the parameters for when is something considered a good source, when is it considered an excellent source, what are the limits placed on those four nutrients for using the term healthy. If you want to get into the quantitative values, we can always go and dig out another slide and get those numbers. It's just to recognize that they have been defined so the terms themselves are meaningful to consumers. They convey something. Consumer doesn't have to know what that number is, but they're intended to make them meaningful claims. So I think an important thing in relation to the topic here is to ask the question, how does FDA derive reference values to create that daily value, to calculate a % daily value? And FDA relies upon authoritative statements, authoritative scientific bodies. And the most commonly used authoritative scientific bodies are the National Academy of Sciences, and specifically the dietary reference intakes, which gives us the RDA value for vitamins, minerals, and other food components. It has also used the dietary guidelines for Americans as an authoritative scientific body. So when it is creating that reference value, it can go to those sources to create those reference values. So looking then at structure function claims, and I have the title of the slide, Structure Function Claims for Dietary Supplements. It's important to keep in mind that the term structure function claim has been defined for dietary supplements. Technically, it has not been defined for food other than dietary supplements, but the kinds of claims that are considered structure function claims are certainly used on both food and dietary supplements. So these claims describe the role of the nutrient or the dietary ingredient that's intended to affect the structure or function in humans. Basically, these are claims about maintaining health. Maintaining a healthy gut, for example, would be a structure function claim. They cannot convey an implied health claim by referring to a disease state or a health-related condition that's related to a disease state, that product would have to then qualify for a health claim. For structure function claims in the US, the manufacturer is responsible for accuracy and truthfulness, substantiating the claim, and of course all labeling must be truthful and not misleading. That differs with other countries. For example, in Europe, EFSA reviews evidence for what we would consider structure function claims in the US. So the US doesn't do that review, but they might be reviewed in other countries. In the US, if a structure function claim is used on a dietary supplement, there's disclaimer language that's required indicating that FDA has not reviewed the evidence. When it's used on a food, a conventional food, not a dietary supplement, it should be related to the nutritive value or other food attributes. You can't just kind of stick it in there to make the claim. It has to be related to the food attributes. So FDA has published guidance on how a manufacturer might consider evidence related to structure function claims. It's not that different from the way you would look at evidence for any kind of claim, but it expects that the manufacturer will go through a substantiation process. So, and there are four main elements that are in that guidance from the Food and Drug Administration. The first being the meaning of the claim being made. When FDA looks at a claim, it looks at the total label. It doesn't just look in isolation at the claim language, but it considers the whole label and what is the expected effect or benefit that is being promoted when everything on the label is considered together. What does the consumer take away with that? Obviously, it wants to look at the relationship of the evidence to the claim. Have the studies specified and measured the dietary supplement that is the subject of the claim, and so there's a specificity there? Have the studies appropriately measured the nutritional deficiency, structure, function, or general well-being that is, again, the subject of the claim? And were the studies based on a population that is similar to the one that is, for which the dietary supplement is being marketed? And does it accurately convey to consumers the extent, nature, or permanence of the effect achieved through the relevant studies? And what is the scientific certainty of the claim? So these are questions that FDA has said the manufacturer should be looking at when they substantiate a claim. Obviously, the quality and the quantity of the evidence is also important. And when we talk, I'll talk a little bit more about quality of evidence in terms of evidence that can substantiate a claim, such as intervention studies, observation studies, and evidence that FDA tends to view more as background support, animal studies or in vitro studies. So background, but not to substantiate the claim. And obviously there are many design factors that can contribute to the quality of the study. And it's important to consider the totality of the evidence, the good, the bad, and the ugly. So not all studies may substantiate the claim, and that has to be taken into consideration when looking at the total body of evidence. So if I look back then on nutrient content claims and structure function claims, I ask myself, okay, what are some of the lessons learned from that might be relevant in the case of the microbiome? So first lesson is that reference to healthy dietary practices can be considered an implied nutrient-related claim. So it puts it into a potential claim category. And in those cases, the total nutrient composition must be considered, not just the one factor that is the subject of the claim in isolation. And that the entire product label or labeling needs to be evaluated to understand the context of the claim. It's not just the single isolated statement, but the whole context that's important. Authoritative references for the amount and type of substance to be consumed to maintain health are needed. You can't say something is a good or an excellent source unless there's a reference value by which to judge whether it's a good or an excellent source. And to my knowledge at this point, we don't have recommended intakes of probiotics or microbes that have been developed by an authoritative source so that you have a way to judge whether something is a good or an excellent source. And scientific substantiation should be in line with the regulatory evidence-based review that is essential for establishing the relevance to health. So then I want to shift and talk a little bit about this concept of producing a health benefit that may be associated with reducing risk of disease. So looking at the fiber issue and looking at disease risk reduction claims. So with the update of nutrition labeling, FDA introduced a new definition of dietary fiber. And it recognized dietary fiber, as non-digestible, soluble, and insoluble carbohydrates and lignin that are intrinsic and intact to a plant, or isolated and synthetic non-digestible carbohydrates that FDA had determined have a physiological effect that are beneficial to human health. And so it's that latter definition that I think becomes relevant here. So the consequence of the new definition is, first of all, what's to be considered intact and intrinsic? And the second question is, what physiological benefits will be acceptable for isolated and synthetic non-digestible carbohydrates, and what criteria will be used to evaluate such benefits? And this is just a note that this kind of definition, this approach to dietary fiber, is actually the Codex approach to dietary fiber, as well as what has been adopted in the US. So we're seeing it introduced in many other countries. In the US, it becomes more relevant because we've mandated the declaration of dietary fiber and nutrition facts. Not all countries do that. So we have to figure out what counts and what doesn't. So for intact and intrinsic, these are obvious sources of dietary fiber: plant-based foods that contain non-digestible carbohydrates, fruits, vegetables, whole grains, legumes, and nuts. I think what's important about these, FDA recognizes that these foods contain other food components which may be associated with a beneficial physiological effect. So it's not asking for further evidence. It's just saying you're intact and intrinsic, so you're considered dietary fiber. It also recognizes that intact and intrinsic could include brands. So it's the carbohydrate is in a food that was produced through a mechanical process, such as milling. It also recognizes that intact and intrinsic can include non-digestible carbohydrates created during processing, such as resistant starch due to flaking, extrusion, cooking, or things like that. So again, you don't have to do anything else. You're now dietary fiber. With isolated and synthetic non-digestible carbohydrates, FDA had two basic ways to look at this. First of all, if you're already an authorized health claim, then FDA already knows that there's a health benefit associated with that carbohydrate polymer. FDA then also said that it would review scientific evidence for a physiological effect, a benefit to health, such as lowering blood glucose and cholesterol levels, lowering blood pressure, improving laxation and bowel function, increasing mineral absorption, or reducing energy intake. And it used the language of such as, so it's not necessarily limited to those, it's just those are the ones we know about. It also has accepted mixed cell fibers, but all the fibers that I've listed here are ones that were already shown to have a physiological benefit to health, so they can be a mixture of them. So what was not considered as a physiological effect of benefit to health was fermentation by microbes, variation in the microbial population, production of short-chain fatty acids, or viscosity, in part because it saw it as an effect, but what was the health benefit? That's what FDA did not know, is what the health benefit might be. So these just go through the kind of scientific substantiation questions. They're similar to what we've already talked about under structure function claims, so I'm not going to go through them again. And then I want to comment briefly on health claims, which are disease risk reduction claims. And it's important to keep in mind health claims are not about treating, mitigating, curing, or preventing disease. They're about reducing risk for disease. And FDA has published guidance on, and in fact this guidance is very valuable because it really shows you how FDA goes through scientific evidence for just about everything in the food and nutrition space. And I'm not going to go through this whole cycle, but so you realize that FDA looks at all studies that are out there. The petitioner is expected to provide all studies, but then there's studies that are useful for evaluation and studies that are not useful. And so when it asks the question, are the studies useful in an evidence-based review, it has to be human studies that evaluate the substance-disease relationship. It sets aside review articles, meta-analyses, book chapters, abstracts, animal studies, in vitro studies, and if they don't pertain to the substance or disease. And I can assure you those are submitted. And just without going through all the details of the health claim review, examples of fatal flaws that show up are no control, lack of relevant statistics, key confounders of risk are not controlled, non-validated biomarkers are used, independent effect is not evident from the study design, observational data without an intake validation, studies in malnourished populations or diseased populations are basically dismiss the study. So lessons learned from fiber definition and health claim reviews: you have to have a specific physiological effect, and the physiological effect has to be related to a health benefit. And FDA has used validated biomarkers, surrogate endpoints. It has used in health benefits that maintain structure or function, such as laxation or mineral absorption. Established health claims are relevant. Reference to a disease state or a health-related condition can result in a product being considered an unapproved new drug. Health claims give a safe harbor for those kind of statements. And again, the scientific substantiation has to follow the regulatory evidence-based review. I just wanted to point out that FDA did have a public hearing this last year on the term healthy, because it will redefine healthy given the new labeling requirements. It asked a whole variety of questions. We don't know where that's going to go, but I just put some potential lessons learned, that it may be moving beyond a specific nutrient profile of a food to consider whether something fits the concept of healthful dietary practices. Giving some consideration to food groups, revising the nutrients to limit, and taking into account consumer perception of the term healthy. So to wind up then, if we think about the main question, I've tried to deal with that main question of approaches, regulatory approaches to the term healthy, by looking at how what we know from existing regulatory frameworks might help us think about considering the health of the GI tract, more of a structure-function approach, but also how FDA looks at a health benefit that can be associated with reducing risk of disease. We were asked to consider some discussion points, and so I felt a short-term discussion point might be looking at decisions regarding the role of the microbiome in maintaining the health of the GI tract. Are there physiological effects associated with the microbiome that maintain the structure or function of the GI tract? Is there a way we can be specific about what those are? Longer term, looking at health benefits related to physiological effects of the microbiome that can be measured in humans. And are some of those physiological effects associated with reducing risk of disease? And if we follow on that, and I think it relates to some of Claire's question, we do have to think about what are the disease endpoints of interest, and are there validated surrogate endpoints for those disease endpoints, because that's what's most valuable in terms of establishing those relationships.